And welcome back. We're doing coverage of the World Healthcare Conference in Washington, D.C. Thanks so much for joining us. In the studio is Corbin Petro, who is President and Chief Executive Officer at Benevera Health, based in the Boston area. Corbin, thanks so much for your time today.
Thanks for having me.
Well, you have an interesting model. You're also you have several partners that you work with, and you have a joint venture model as well. Talk a little bit about that.
Yeah, so Benevera Health is a tech-enabled health services company. We focus on population health and patient-centric care, but we were created out of a joint venture between a health insurer, Harvard Pilgrim Healthcare, and then 4 hospital systems, the largest of which is Dartmouth-Hitchcock. So the second piece of our model is that it's an insurance joint venture. So our 4 hospital systems share in Harvard Pilgrim's business in New Hampshire and the financial risk there.
Okay, and so what has that enabled you to do, having these different partners in the different areas?
So, you know, we serve as an operating partner with our healthcare system participants, and we do that, obviously, it's enhanced through the financial risk that they share. So it's moving our 4 hospital systems toward value-based care and toward risk-based contracts, and then it allows us to help them in that journey by working with them and with their patients. So, you know, helping them identify patients at risk and in need of care, as well as working with them to help benchmark physicians and change how care is delivered.
And have you seen good data on how population health communities that you work with have improved some of their statistics and in terms of their outcomes?
Yeah, so we work directly with patients, and that's where we've seen the most benefit. So we have teams of nurses, community health workers, social workers, patient engagement specialists, pharmacists, doctors, who outreach to patients and really try to figure out what needs they have, whether that's understanding their insurance plan, getting connected with a doctor, understanding their chronic condition. We help folks with applying for fuel assistance, whatever it may be. And so we found that sort of multi-pronged approach that really has a broad set of services is where we're really able to sort of build trust with patients and engagement. So that engagement piece has then led to, obviously, reduced utilization of the ED and reduced readmissions. So we've seen a significant reduction in cost.
And do you feel that your approach is unique?
We do. So obviously focusing on the whole person and having a locally based team where we're able to connect folks with resources in their community, that's a unique model. We're able to go to their home if we need to. We're able to really try to meet a broad set of the patient needs. Obviously, also having the connection back to the physicians in their community through our financial model is helpful because we get the input and the engagement of the provider who may be working with patients.
And how else do you think you're working to really improve people's approach to value-based care?
So we help with data and analytics. That's the other prong that we really help work with. So through our model, we integrate claims and EMR data. And we also bring in social determinant data through census and other patient-reported data. That really helps us to both identify patients through predictive analytics, but it also allows us to find out the right types of engagement that might be best suited for that patient. So we do that not only for our partners, but we do that obviously outside of the joint venture as well.
What are some of the needs that you've found when looking at social determinants of health that people have come to you with that they found challenging, and then you were able to address that?
Yeah, so we find that you never really know what the patient needs until you start engaging with them. So I always say that data can only take you so far. So it can help predict that somebody might be at risk, but not necessarily exactly what interventions might be helpful to them, which is why we sort of empower our teams to really think broadly about what we can do for them. So an example is a patient we had a couple months ago where we started engaging with him because he had some behavioral health issues. He had spent some time in an inpatient. So we started working with him, and our social worker was talking with him, and he basically said, well, I was in the ER last night because my roommate beat me up again. So we went and we continued to engage. This gentleman went into his home. He was a 50-something male with 2 other male roommates, and we obviously found that the home environment was unsafe. This was a commercially insured working individual. So we worked closely with a local housing agency, not a Section 8, but a sort of income qualified housing. Got him out of that not healthy home situation within 10 days, and he hasn't been to the ER since. So those are the types of interventions that we do that, we've talked a lot at this conference about social determinants, and how that can help identify people. But I think the next step is then figuring out how you then help those patients and those people really seek better health outside of the clinical care delivery sphere.
Are you finding that that's a growing trend, that health plans need to start looking at social determinants of health, because sometimes that's where the basic issues are? Yeah,
I think the ones that are focused the most on it are for patients who are Medicaid and Medicare. So they've started obviously having ways that are reimbursable. You know, this goes back to the ways to truly incentivize payers and providers is to have something embedded within the fee-for-service system. But I think being able to think more broadly in a value-based world and thinking more creatively, it isn't always about tactics that can be paid for in a fee-for-service world. I think that's going to be sort of a growing trend after it's sort of operationalized and proceduralized within the Medicaid and Medicare worlds. I think the misconception is that the commercial population doesn't have as many needs. So the segment of the population that's working, getting their health insurance through their employer, and we've found that there's significant need in that community as well.
What are some questions you're hoping to address here at this conference, things that you'd like to learn more about?
I think I'm trying to understand where other systems are in their work. We also found that smaller hospital systems, rural health systems, are trying to sort of figure out how to attack some of these problems. So I'm trying to understand where they are in all these conversations. Most of the folks that you see on stage are working with larger health systems, larger payers who aren't as resource shy as some of the smaller systems. So I want to understand sort of where they fit in the puzzle. I also want to understand how people aren't just taking that social determinant data, but are actioning on it.
All right, Corbin Petro, thank you so much for your time.
Thank
really
you.
Appreciate it.
Thank you very much.
And thanks for sticking with us. We have much more to come.